All right, let's talk geriatrics. You know, these questions on the test, they feel like they're specifically designed to trip you up. The patient is complex, there are a million details, and the most obvious answer, it's almost always wrong. So in this explainer, we are not just going to memorize facts. We're going to build a new mindset. We're going to learn how to see the patient through the examiner's eyes and really focus on the why behind all the symptoms. You ready to get started? Let's do it. So take a look at this. This is about as classic as it gets. An elderly patient, a whole pharmacy of meds, a fall, and now confusion. My first instinct, is to tackle these problems one by one. Okay, he fell. Did he hit his head? Is it a stroke? Then separately, why is he confused? But that's exactly the trap. The TUS exam is testing something much deeper. It's asking if you're just chasing symptoms or if you're looking at the whole geriatric picture. And this is where we have to start. The absolute key to cracking geriatrics isn't memorizing syndromes. It's about understanding the fundamental physiological changes of aging. Every single high-yield topic, from how they handle drugs to why they fall, it all stems from these core principles. If you can understand the why, you can reason your way to the right answer, even when the question looks impossible. It's all about the foundation. And in geriatrics, pretty much everything starts with the kidneys. This is ground zero. It is the first domino to fall. After a certain age, the GFR just consistently, progressively drops. We're talking about 1 ml per minute, every single year. And that one simple fact changes how the body handles, well, pretty much everything, but especially medications. This is the master key. Okay, hold on. That makes perfect sense. If the GFR is going down, then serum creatinine has to go up. I mean, that's just basic physiology 101. So we should be looking for a high creatinine. But the slide asks about a TUS trap, so I'm guessing I just walked right into it, didn't I? It's not that simple. You did. And this is one of the most elegant traps on the entire exam. The secret isn't just about how the kidneys filter. It's about how much creatinine is being made in the first place. Remember, creatinine comes from muscle. And what happens to muscle mass in older adults? Sarcopenia. They have way less of it, so their baseline production is deceptively low. This means a normal creatinine of, say, 1.1 in an 85-year-old woman could actually be hiding severe renal failure. The takeaway here is critical. Never, ever trust a normal creatinine in an elderly patient without thinking about their muscle mass. Okay, so now that we have that core physiologic principle in our minds, let's see how it actually shows up in the clinic, and more importantly, in our exam questions. We're moving from the microscopic to the macroscopic. We're going to connect the dots and look at the classic geriatric syndromes. This is the bread and butter of TUS, where they test your ability to tell very similar presentations apart. And here they are, the 3 Ds. If there's one area that trips students up, this is it. Examiners absolutely love to blur the lines between these three. So looking at our patient in that first case, he's got fluctuating consciousness and he's disoriented. Is it delirium? Is it his underlying dementia getting worse? Or could it even be some weird presentation of depression? Your ability to tell these apart is what gets you the point on the exam. Now, this table breaks it all down, but for the TUS, you have to laser focus on one key feature: onset and course. Delirium is acute and it fluctuates. This is when the family says he was perfectly fine yesterday. That's your clue. Dementia, on the other hand, is a slow, insidious decline over years. So in our case, that phrase fluctuating consciousness is the big, flashing neon sign for delirium. It's an acute change, and you have to treat it like a medical emergency. Okay, so we've identified delirium. We use the acute and fluctuating course to nail the diagnosis. The very next question Tusk is going to ask is about management. So what is the high-yield, first-line medication we need to have locked in our minds? For agitation and delirium, the answer they're looking for is haloperidol. But, like all good TUSAS facts, there's always a crucial exception. What if the delirium is caused from withdrawal from alcohol or benzodiazepines? Well, then the treatment is the exact opposite. You give benzodiazepines. Knowing the main rule and the most important exception is absolutely key. Okay, let's pivot. Let's go back to the other major part of our opening case, the fall. A fall in an elderly patient is never, ever just a fall. It's what we call a sentinel event. It's a huge warning sign that there's a serious underlying problem. And one of the most common and most testable causes is orthostatic hypotension. First things first, the definition. You have to know these numbers cold. This is a pure recall question they can just throw at you.
a systolic drop of 20 or more, or a diastolic drop of 10 more upon standing. It's simple, but you gotta know it. But again, let's stick with our theme. It's more important to understand why this happens so often in older adults. And here's the mechanism, step by step. When any of us stands up, blood pools in our legs, and less blood returns to the heart. In a younger person, our baroreceptors immediately sense this and fire off signals to increase heart rate and constrict blood vessels. Our blood pressure stays stable. But in our elderly patients, those baroreceptors, they're just not as sensitive anymore. They're blunted. Their response is slow, it's weak. And the result is a sudden drop in blood pressure, not enough oxygen getting to the brain, and dizziness, or even a full-blown syncopal episode.
So orthostatic hypotension is just one piece of the puzzle. What else is a TU's vignette about a fall gonna throw at us? Well, they'll usually include a whole bunch of other risk factors. Polypharmacy is a huge one. They love to list blood pressure meds and diuretics. Then you have sensory issues, like poor vision, so the patient can't see hazards, add in balance problems, and maybe an underlying arrhythmia, and you've got a recipe for disaster.
All right, we've covered the big concepts and the right mindset. Now let's switch gears and do a high-yield blitz. These are the spot facts that you just need to know cold. They often show up as single-answer questions, so let's run through the most common ones you'll see. The most common arrhythmia, hands down, is atrial fibrillation. As the heart ages, fibrosis in the atria makes it way more susceptible to these chaotic electrical signals. And what's the biggest risk you have to remember? Embolic stroke. The most common valvular disease is calcific aortic stenosis. You can just think of this as a simple wear and tear process, like atherosclerosis of the aortic valve itself. And don't forget the classic triad of symptoms it causes: syncope, angina, and dyspnea. Next up, the most common electrolyte disturbance you'll see is hyponatremia. And on the exam, this is almost always going to be due to SIIDH. Older patients are just really prone to it, often triggered by their meds or some underlying lung problem. This leads to water retention, which dilutes the sodium in the blood. Now for a tricky one. When you see hypercalcemia in an elderly patient, especially one who's hospitalized, your first thought has to be malignancy. Yes, even before primary hyperparathyroidism. Why? Because cancer is just so much more common in this age group. Tumors can secrete a substance that acts just like parathyroid hormone, driving those calcium levels way up. And finally, the most common cause of an upper GI bleed is still a peptic ulcer, and this is often linked to chronic use of NSAIDs for things like arthritis pain. Those drugs are notorious for damaging the protective lining of the stomach. It's a classic association they love to test. Okay, we've built our foundation, we've gone through the big syndromes, and we've nailed the rapid-fire spot facts. Now let's bring it all back home. It's time to solve that initial case, but this time, using our new mindset.
So let's break it down. That fluctuating consciousness, that's our buzzword for delirium. The fall? We're suspecting orthostatic hypotension, probably made way worse by his antihypertensive meds. And if his labs come back and the creatinine looks normal, we're not fooled. We're immediately thinking about his low muscle mass and that creatinine trap. So our job isn't just to give him something for the agitation. Our job, and the correct answer on the test, is to find and treat the underlying trigger for the delirium. Is it a UTI, pneumonia, an electrolyte imbalance? That's how you crack the case.
And that really is the main takeaway. You have to burn this into your brain. The geriatric patient is not just a small adult. Their entire physiology is different. Their bodies react differently, their diseases present differently, and their lab values can lie to you. And that difference, that is exactly what TCOS is testing. It's not about how many facts you know, it's about whether you understand this fundamental shift in physiology. Master this mindset, and you will master geriatric questions.